I'm very pleased to introduce to you Dr. Kamal Masaki, who is an important person here. So she's not only on our board of directors, but she's also the chair of the Department of Geriatric Medicine at the John A. Burns School of Medicine. So important. And then also, she is the director of research for Kuakini's research program here. And I think she's going to refer, some of the things that we've learned from the research that has been conducted here at Kuakini. So with that, let me introduce her to you, and please welcome her to the stage.
Thank you, ladies and gentlemen. Thank you for being here today, early morning on a Saturday. I hope that you will learn something about this very important topic. As Gregg mentioned, I'm the chair of geriatric medicine at the John A. Burns School of Medicine. And our field, geriatrics, deals a lot, unfortunately, with this condition. So I'm going to start with this very dramatic statement. Alzheimer's disease is a public health crisis. I want to ask the audience, how many of you have had any personal experience with any form of dementia, whether it's in your family members or in good friends, any kind of loved ones? Could I see you raise your hands? I'm seeing a lot of hands. My father died from Alzheimer's disease many years ago, and it was one of the most difficult things for me. I was immersed in the field of dementia. I taught about it, I took care of patients with it, I did research on it, and I felt so helpless that I felt like I couldn't really do that much to help my dad. Fortunately, things have changed. There's a lot more that's happening now, and there's a lot of research going on, so I hope I'll show you that there's some rays of hope on the horizon. So there are over 7 million people in the United States living with Alzheimer's disease or another form of dementia. It's the 6th leading cause of death across all ages, and 1 in 3 seniors dies with some form of dementia. In Hawaii, we have over 31,000 people, and there are almost 12 million Americans who are providing unpaid care for people with dementia. I'm going to ask another question. How many of you are caregivers or have been in the past caregivers for someone with dementia? Could I see a show of hands? Please give a little bit of applause to yourself. This is the hardest job in the world, being a caregiver, especially for a loved one, to watch that. Fortunately, we have a lot of resources in our community. I wanted to introduce L.J. Duenas. He's in the back of the room on that table there. He's with the Alzheimer's Association. We invited them to come here, and we're very lucky that they came here, and they provide a lot of information on dementia. So when we look at percent change in cause of death between 2000 and 2022, on this graph, there's breast cancer, prostate cancer, heart disease, stroke, HIV. For the first 4, they're almost the same. There's been not much change over those 22 years. HIV has actually gone down dramatically. The bar on the right is dementia, and it's gone up, and it continues to go up. So it's gone up by 142%, and the rate continues to go up as the population ages. So before I talk about dementia, I'm going to talk about some good things, healthy brain aging. In the past, we used to think if you happened to be unlucky and it was just in your fate, you would get Alzheimer's disease. There's nothing you could do about it. Now we know that that's not true. We do know there are things we can all do to keep a healthy brain, which actually can start out from childhood. So this is what we define healthy brain aging as. This is what we all want as we get older, to continue to think, reason, remember, carry out our tasks, live a purposeful life, function independently, maintain our social connectedness with our family and friends, and keep our own sense of identity. We all hope, as we age, that this is what we will continue to have. Unfortunately, there are some changes in the aging brain, even in the absence of disease. We do know that certain parts of the brain shrink, especially the hippocampus. The hippocampus is the memory center. It's actually located kind of deep within the brain. It's a very small center, but it's very, very important. That's what holds our memories. We do see a slight decline in the ability to learn new things and retrieve information. Things like remembering names, finding words. I'm seeing a few people nodding in the audience. We all feel that, right? There is certainly that little bit of decline. I've actually had patients in the past who, they never had a chance to go to college when they were younger. Not because they weren't smart, but because they didn't have the opportunity. They grew up in an age when they had to go to work right out of high school, sometimes even before they ended high school, to support the rest of the family. Some of them, after they retired, they say, now I'm taking college classes. That's always been my dream. And they come back and they say, I can do it. I can still learn, I can still memorize, but it's not the same as when I was 18 or 20 years old. And all of us notice that, right? When I try to memorize things now, it takes me quite a bit longer. When I see my daughter doing it, it seems much easier to her. There's also difficulty in multitasking. But some cognitive areas, things like vocabulary, problem solving, impulse control, judgment, the things I call wisdom, actually get better with aging. So it's not all bad. Now, this is, of course, in the absence of disease. So what are the things we can do to keep our brains healthy? I think these are the four main pillars. One is stay physically active, socially active, mentally active, have good nutrition, and reduce your risk factors for heart disease. So I'll go over each one of these a little bit. For physical activity, now there are more and more studies that have shown that the more physically active you are, and this is throughout your life, not just in old age, the better your brain does. They've actually done some studies now in people with early cognitive dysfunction, so people who are having some memory problems, and they're showing if they start getting physically active, their memory decline is actually slowed. So we know that physical functioning is good for the brain, physical activity, exercise. And it doesn't need to be intense exercise. I'll show you some data from our own research here that shows that just simple walking can be very good for you. Social activity. We found this out very dramatically during COVID. During COVID, we were all socially isolated, partly because we wanted to be safe, partly it was forced on us. And what we found is people who had any kind of cognitive problem actually declined much more dramatically during that time because of that social isolation. So we know that social isolation is really bad for the brain as well as for the rest of our health. Mental activity. The more mentally active you stay, the better it is for your brain. It's kind of like a use it or lose it. Just by being here, you are being mentally active. You're being physically active. You're being socially active. So these are the types of things I really encourage. For social activity, I encourage people to just do the things they like to do, go places they want to go, see the people they want to see. Volunteering is really good for all of those things. Volunteering is good for physical, social, as well as mental activity. For mental activity, you will see some claims, buy this book and you won't get Alzheimer's, or play this puzzle and you won't get Alzheimer's. There is no such magic bullet, just like there's no magic pill you can take to stay healthy, right? So don't believe all the hype, but do things that you like to do. If you like to read. Before I was standing at the back of the room, I was doing Sudoku on my phone because I find that kind of fun. I like numbers. So find something that you really like to do and stay mentally active as much as you can. Don't just, after retirement, sit on the couch and watch TV. Good nutrition is a big factor. And from all of the diets, the best studied one has actually been the Mediterranean diet. which is quite common sense. It's lots of green leafy vegetables, fruits, lean proteins, not the high-fat ones, cutting back on the bad things, the saturated fats, salt, having enough liquid intake, making sure that you do whole wheats rather than whole grains rather than the refined grains. So they've shown now that the countries that follow the Mediterranean diet again through their lifetime, they tend to have lower rates of Alzheimer's disease in old age. So I've been trying to do that for the last 6 months. I've been sort of successful. Every now and then I don't do so well, but I'm really trying. The other one is this heart-brain connection. Reducing risk factors for heart disease is incredibly important. So what are they? Things like high blood pressure, diabetes or blood sugar, controlling high cholesterol, avoiding obesity, stopping smoking, staying physically active. All of these are really important. Now, I want to stress something. Some of these conditions, the top two are probably the most important factors, the high blood pressure and diabetes. Those are the two most important factors that are really linked to brain health. Most people, when they develop high blood pressure or diabetes, do so in middle age. Some do in old age, but most people do so in middle age. It's really important you don't wait until old age to get these under control. That might be too late. So as soon as these conditions are diagnosed, we're trying to train physicians to really make good control of their blood pressure and sugars so that it avoids problems in their brain later down the road. The country has decided this is important enough that they've actually created a Healthy Brain Initiative roadmap. You can find it on the internet. You can just Google CDC Healthy Brain Initiative roadmap and you can find it. It's a pretty large document if you want to read it, but it does have a lot of very important information. And Hawaii, the state of Hawaii, also has a state plan on Alzheimer's disease and related disorders. I'm one of the working members of that group, and we've been trying to look at various aspects of dementia, not just the clinical care side, but also looking at research, at prevention, lots of other things. Education, that's a big factor as well. So now that I've talked about healthy brain aging, I'm going to move on to dementia. First, what is it? Before I tell you what it is, I'll tell you what it's not. First one, the myth, is that memory loss is the same as senility or becoming senile, and it's an inevitable part of becoming old. We know that that's not true. We know, all of us know people in their late 80s, 90s, even beyond, centenarians, who have very, very good memory. So we know just being old doesn't mean you have to get dementia. Senile means old. So if you say dementia is equal to becoming senile, that means everybody is going to get dementia, and that's not true. The second myth is that nothing can be done, so why bother? I've heard even doctors tell me that. They say, do you have a cure for it, for Alzheimer's? And of course the answer is no, we don't, although there is a lot of research happening. Despite that, there's so much we can do. So I hope by the end of this talk, you will agree with me that it's very important to look for it and to find it early on. The third myth is that most people don't want to know, sort of like the ignorance is bliss theory. And actually, when they've done studies asking older people, that's not true. The majority of older people have said, if I do develop problems with my memory, if I do develop dementia, I would want to know about it. So I think all of these misconceptions contribute to the under-recognition of dementia. So what are the facts? First, it is not normal aging. It actually represents a group of diseases, not just a single disease. The second fact is it's common, underdiagnosed, very, very expensive, and it's a fatal disease. People die because they have dementia. And the other fact is that people with dementia should have a thorough evaluation by a physician who's expert in the condition. People ask, who is that? It could be a geriatrician, could be a neurologist, could even be some psychiatrists specialize in dementia, particularly those in geriatric psychiatry. But find somebody who's good at dementia. Some of the primary care doctors are also quite good at dementia, so don't assume just because they don't have that specialized training. So you need to ask a lot more questions to your doctor about how comfortable they are with this condition. So this is the definition of dementia. You see acquired deficits. What does this mean? If somebody's born with intellectual problems, with mental retardation, that doesn't count as dementia. This is somebody who was intellectually normal and now has a change and has developed problems with their intellectual abilities. We do see a deficit in memory, but not only memory. It has to be memory plus at least one other cognitive domain. It has to be bad enough that it's affecting your functioning, your social connections with family and friends. If you're working, it's actually affecting your job performance. That's when we call it a dementia. And there has to be an absence of what we call delirium. Delirium is a very special condition that's seen mostly in the hospital setting. I'm going to ask you a question again. How many of you have gone to visit a loved one in the hospital? Their memory was fine before, but in the hospital, you're noticing they're really confused. They're kind of not themselves. You can see there's a change. That's usually a delirium. It's an acute change that you see in someone, and it's usually linked to any kind of acute illness. And fortunately, most people who have delirium, it needs to be treated, it needs to be recognized. But many people who have delirium, at least that brain fog will clear after their medical condition has been treated, after they're out of the hospital. So in the hospital is not a good time to make a diagnosis of dementia. As a geriatrician, I've been consulted in the hospital to say, does Mr. X have Alzheimer's disease? I do a very good history, and I talk to family members, and I find out, actually, this sudden change happened a week ago. But then when I dig deeper, I find out, for the last 5 years, we've noticed some changes. I can't make that diagnosis right away. I have to wait until the patient is stable, out of the hospital, back at their baseline. But I can say this patient probably has a delirium, an acute condition, and I have to check and see whether they have an underlying dementia after that delirium clears. Similarly, if somebody has a major psychiatric illness, a common one for older folks is major depression. It's really not possible to make the diagnosis of dementia in the presence of a major depression. We have to treat the depression first, see what happens, and then decide whether the patient has dementia. There's also this condition called MCI, or Mild Cognitive Impairment. This is like a pre-dementia syndrome. We see a subjective complaint about memory. It may be the patient, but more commonly, it's a proxy informant. It's a family member, it's a friend. Particularly in Alzheimer's disease, patients with Alzheimer's don't realize they have a problem most of the time. There's what we call lack of insight. So when you ask a patient with Alzheimer's disease, how's your memory? They will say, my memory is great, doc, because they don't realize they have a problem. That's why I think that's one of the reasons why dementia is missed so often, because the patient themselves doesn't realize. So for MCI, you have to have a complaint from either the patient or a proxy informant. You need to see cognitive deficits in at least one domain. It has to be memory, language, attention, executive function, visuospatial function. Something has to be abnormal on testing. But they're functioning well. So they're functioning well with their family and friends socially. If they're working, they're still able to do their job. Because if they had a functional impairment, it would be dementia already. So this is before it gets to the stage of becoming dementia. Now, why do we care about this? They're still functioning, right? This condition has a high risk of converting to Alzheimer's disease. We know the rate of conversion is about 12 to 15% per year. So in about 5 years, half of people with MCI will have a diagnosis of dementia. This is a really hot area of research. Why do half convert and why do half not convert? How can we keep everybody from converting? That's what we want to know. So this is a really hot area of research, and hopefully we'll get some answers in the next few years. So how common is it? 13% in people over the age of 65. When you hit 85 and over, it's almost half. I did say this is not an age-inevitable disease, but it is an age-related disease for sure. We see a geometric increase in prevalence of disease after the age of 60. After the age of 60, the prevalence doubles every 5 years. So if you look at this graph, I don't have a pointer, so I'm going to just walk. So this axis here is age. And it starts with 60, and I think it ends with 85. And on this axis here, the y-axis, it's the percent who have dementia. The blue line is people who have dementia that's bad enough that it's affecting their functional status. The red line includes those who have MCI, or the mild cognitive impairment. You can see it's a curved line because it's doubling every 5 years. It's not a straight line. It goes up geometrically. And over the age of 85, almost half have some form of impairment. So that is definitely, age is definitely an issue, although it's not age inevitable. The reason why we see such a steep curve is it's a long duration of disease. People live with Alzheimer's in particular for many, many years, sometimes for decades. It is a major cause of disability, and it's the primary reason for being institutionalized. So being put in a nursing home or a care home, it's the most common reason why people are in a nursing home. In Hawaii, because we have fewer nursing home beds than the national average, I think about 80% of people who are in nursing homes are there because they have a dementia. And it's a very costly disease. Over $380 billion annually for care, and even more than that, over $400 billion for caregiving and lost productivity. And really, for that second part, the families are bearing the cost. I personally know so many people who've either had to quit their jobs early or maybe are underemployed. They had to take an easier job or something that they're overqualified for, or they're working part-time because they're also caregivers for a loved one. So it is a huge financial burden, not to mention the huge emotional toll that it takes on patients and families. Now this next slide I'm going to show you is about subtypes of dementia, and this is something I really want everybody to understand. So dementia is the umbrella diagnosis. Under dementia come all the subtypes. Alzheimer's disease is the most common subtype of dementia. We see it in about 60 to 80% of all dementias are Alzheimer's disease. The next most common is vascular dementia, which is stroke-related, and several others. But really, I've had people again come and tell me, they say, I was told I have Alzheimer's, but I don't have dementia. That cannot be, because Alzheimer's is the most common type of dementia. Okay? So when we look at white populations, the studies have shown that Alzheimer's is predominant. So if you look at that pie chart on the right, the blue pie, which is the big chunk of it, is Alzheimer's disease. And it's seen in, again, depending on which study you look at, anywhere from 60 to even 75, 80%. Vascular or stroke-related dementia is the little red wedge. That's about 10 to 20% in most studies. The yellow is Parkinson's disease and Parkinsonian syndromes. And then there's a whole boatload of mixed and other dementias. I'm going to show you some more slides that talk a little bit about the 4 most common types of dementia. So Alzheimer's disease, again, is the most common. And the reason people get it, this is not a psychological disorder. This is a medical condition. When you look at the brain on autopsy, we actually see these two abnormal proteins that are deposited within the brain. We see something called amyloid plaques, which is beta amyloid protein, which surrounds the cells of the brain. And we see something called tau protein, which we actually see inside the cells of the brain. I'll show you some better pictures of this later when I talk about Alzheimer's disease. Vascular dementia, or stroke-related dementia, is really because the brain isn't getting enough blood flow. There have been blood clots, there have been strokes. Sometimes the blood clots are microscopic. So in our study here at Kuakini, we actually found something called microinfarcts, which is you can't even see them on a scan, but you can see them in the microscope when you look under the microscope. So some can be large strokes, some can be really tiny, really almost invisible strokes. But it's really because there's not enough blood flow to the brain. There's a condition called Lewy body dementia, which we're getting more and more attention to recently. This is a different protein now. It's called alpha-synuclein protein, called Lewy bodies, which are also deposited within the brain cells. This type of dementia is a little different in presentation. It's a little quicker. The progression is a little quicker than in Alzheimer's disease. We see a lot more fluctuations, people going up and down, up and down. And we also see that they have a lot of behavioral issues, including very vivid hallucinations. So in order to tease out which type of dementia it is, most of the time it is going to be Alzheimer's disease, but that's why you may have to see a dementia specialist if you have anything atypical. And then the last one is frontotemporal dementias, where they have other different proteins, tau and a protein called TDP43, which are also deposited within the brain, but mostly in the front of the brain and in the sides of the brain. And this dementia is a little different. It tends to be a little younger onset. So it's not, mostly it's people before the age of 60 or 65, maybe before 70. And we see a lot of personality change in this type of dementia. So this type of dementia can be very, very disturbing for family members. Again, we see all of these symptoms in all of the dementias. So if you're not sure, if you have a family member or friend, go and see an expert. I want to bring some attention to this amazing study that has been done at Kuakini for the last 60 years. We actually had our 60th anniversary 2 months ago. And we did do a little celebration. We did a newsletter. The Kuakini Friends, I think, had an article on it. And we even contacted some of the participants' children who have been participating in other studies. So I've been really honored to be part of this study for decades, ever since I first came to Hawaii. And it's completely changed my career path. So if any of you have family members who were part of the Kuakini Honolulu Heart Program, or who are currently offspring, who are participating in the offspring studies, please give them a big thank you from me. Because myself and many trainees over the years have worked with the wonderful data from this study. So the Kuakini Honolulu Heart Program started in 1965 in 8,006 middle-aged Japanese American men. And it started out as a study of heart disease and stroke. 25 years later, in 1991, now the men were older. They were ages 71 to 93. And somebody at the NIH decided, wow, this would be a great opportunity to also study dementia, which is now common in aging. So the Honolulu-Asia aging study began then in the survivors of the Honolulu Heart Program. So the purpose of the study changed a little bit. We were still studying heart disease and stroke, but now we added in cognitive function, dementia, disability, depression, other things that are more common with aging as well. And this is what we found. So let me again orient you. The axis on this side, the horizontal axis, is the age groups. The one on the left is 71 to 74, all the way to the right, which is 85 to 93. And on this y-axis, the vertical axis, is the percentage with dementia. The blue bars are those who have dementia which meets research criteria, and the red bars include the MCI, or the mild cognitive impairment. And you can see it's a curved line, just like it is with the national studies. And when you look at 85 and above, again, almost half have some form of impairment. So this data showed our Japanese American men here in Hawaii were very similar to the studies done on the mainland. But this next slide shows how they were different. So this slide, again, looks at the same age groups. Now this is the subtypes of dementia. So we look at the two most common subtypes in our cohort, which is Alzheimer's disease and stroke or vascular dementia. The blue is Alzheimer, and the red is vascular or stroke. You can see in the youngest age group, stroke was actually more common. After that, Alzheimer's overtakes and becomes number one. But the ratio is not how it is in white populations. You saw that pie chart, right? Where the majority was Alzheimer's and vascular was this small piece. In Japanese populations, we find that actually vascular dementia has a bigger impact. This also is seen in studies in Japan, China, Korea. So we are not the only ones, but we showed even here in the United States, our Japanese American population was a little different from the white populations. The type of stroke was also different. In white populations, usually the vascular dementia is because of multiple large strokes. In our Japanese population, we found many of them were due to tiny strokes, which were actually asymptomatic. So when you ask the patient, have you ever had a stroke? The answer was no. And when we examined them, we could not find weakness or anything like that. So I can see why even doctors would miss it. The only way we found it is when we did a CT scan, and we found that they had 3 small strokes that they had had before, which were completely asymptomatic. So again, this shows why it's so important that we don't just believe all the studies on the mainland and say we can use them for everybody here in Hawaii. We need to do it in our local populations as well. I hope I can convince you that early detection is important. The biggest issue for me is treatment of reversible causes. There are some things that can cause a cognitive syndrome that can be reversible. But if you wait too long, they will become irreversible. So it's very important that we find them early. Even more important, I think, is improving treatment of underlying conditions. I want you to imagine, let's say there's a patient with Alzheimer's disease. They go to their doctor's office. The doctor talks to them. They're socially appropriate. It's early in the disease. Doc says, how you doing? I'm great. How's your memory? My memory is great. Now the doctor examines them, gives them medications, gives them advice about diet or exercise or how to take the medications. The patient's smiling and nodding and remembering nothing. How do you expect them to follow through with that? Then we call them non-compliant patients. They're not non-compliant. They can't remember. They should have a caregiver in the room with them who can remember for them and make sure they do those things. So it's really important that we look. The other thing is it reduces ineffective and expensive crisis care. We don't want to find out that the patient has Alzheimer's disease the first time in the emergency room or because something really bad happened. The other issue is patient and family education. Advanced healthcare directives and planning for healthcare. May I ask, if you have an advanced directive, durable power of attorney, anything like that, could you please raise your hand? I see most hands raised. That's great. If you didn't, please do it. That's actually a topic maybe we could have Donda in the future, because I think that's a really important thing for adults of all ages, not just people who are in older ages. If we catch people late in a dementia, we cannot have them do an advanced healthcare plan. They are no longer able to do it. So we want to catch them early so that they can do it if they haven't already. And then financial planning. I told you this is a very expensive disease. So the family, patient and the family need to plan for this. There are safety issues. I have a whole slide on safety, which I'll show you later. And then connecting people to community services, like LJ and the Alzheimer's Association. They can provide so much help and support for both patients and families. I want to show you about under-recognition. So again, this is data from our Kuakini study. If you look at the x-axis, there are 3 columns, right? The left column is those who had no dementia. We're pretty sure because we put them through our intense research criteria for dementia, and we're pretty sure they didn't have it. The second column is those who had MCI, or mild cognitive impairment, and the third met research criteria for dementia. We asked their caregivers, usually it was a spouse who came, sometimes son or daughter, and we asked them, does Mr. X have a problem with his memory or thinking? I want you to focus on the red in this, which is no problem with memory or thinking. Even among those who met research criteria for dementia, 20% said no problem. Among those with MCI, 50% said no problem. We don't go around quizzing our loved ones every day and doing memory testing on them every day. You're not going to notice it because it really might be creeping up on you. So if you're seeing them every day, you may not even notice. This one was even more alarming. The same 3 columns, no dementia, MCI, and research criteria for dementia. We asked, were they ever referred for evaluation of their memory problems? And again, if you look at the dementia group, 40% had never had an evaluation among the dementia group. Among the MCI group, only 5% had had an evaluation. So the majority of people are not being evaluated. So they're not finding things early, right? So it's really important that we do that. This one was actually not from the Honolulu Heart Program. This one was from a study done by one of my previous fellows, who's now a professor at UCSF. And he looked at one of the group practices, very, very good internal medicine group practice, and he asked them, do patients have dementia? And he actually examined several hundred of their patients and looked to see how much of the dementia was recognized and non-recognized. And this is what he found. Among all dementias, 2/3 was unrecognized. Among mild dementias, 90% was unrecognized. Among moderate, it was half. Okay, none of the severe dementias were missed, but should we be proud of that? I mean, a severe dementia, a layperson could diagnose, right? So what this means is, and this is not different from other national studies, from either the United States, even from Australia. I've seen studies that have shown this. The majority of dementia is missed if you don't look for it. So we're trying really hard to train physicians to look. For symptoms and diagnosis, these are some of the common symptoms. Again, depending on the subtype of dementia, you may see more of one or another, but memory loss tends to be the hallmark. Short-term memory first, then even long-term memory. I think this is one of the things that fools people. You ask people about memory and they say, oh, mom has a fabulous memory. She remembers things from my wedding 40 years ago. That's true, but she forgot what she ate for breakfast half an hour ago. That's the thing. So the long-term memory sometimes can fool people into thinking there is no problem. Disorientation, to date or to place, eventually even to person, eventually in the end stages, they won't recognize family members. They may not even recognize themselves in the mirror. So disorientation can be really bad. By disorientation to place, I don't mean when you're traveling and you get lost. We always get lost when we're traveling, right? I mean, that's just part of traveling. I'm talking about having a hard time finding your way home from the grocery store to the home you've lived in for the last 40 years. That's the type of disorientation, things that you should know and you don't. Difficulty with naming and understanding, maybe even having a conversation can be really difficult. Lack of insight, especially in Alzheimer's disease. Early in the disease, some patients may show depression, and we really need to treat that depression if they have it. Behavior problems and personality changes can be really common. That was the first thing I noticed in my dad. was personality change, before memory. My entire childhood, I had never seen my dad raise his voice once, not once. And on one trip back, my parents lived in India. I grew up in India. On one trip, I saw him lose his temper twice. And I was like, oh my God. And my husband, who was with me, said he thought it was nothing. But I knew my dad. And sure enough, that was the very beginning for him. It was a personality change. Wandering can be really difficult and actually can be dangerous. And being socially inappropriate and having poor judgment. I won't go through this slide very well, but basically this just shows that the different parts of the brain, so on the left is the front of the brain and on the back is the back of the brain. The different parts of the brain have different functions. So for example, the frontal lobe is really important for personality, behavior, social skills, planning. Whereas the temporal lobe is more important for memory, mood, and other things. So all the symptoms that we see are related to where the lesions are. So if it's stroke-related, depending on where the stroke is, you'll see more of one symptom than of another symptom. For diagnosis, the history is the most important thing, not just from the patient, but also from a proxy informant. We need a family member or friend there to give corroboration about some of the things we're being told by the patient. We do a good physical exam, focusing on the neurological exam. We do memory testing, and there are very standard memory tests that are available that doctors have been trained in. For those who do have dementia, we do blood tests to make sure that there's nothing reversible. We always do some form of imaging, either a CT scan of the brain or an MRI scan of the brain. In the past, Alzheimer's was a diagnosis of exclusion. If we didn't find anything else, then we were left with this is probably Alzheimer's disease. Now that's not true. Now there are actually diagnostic tests that we can say for sure that this person has Alzheimer's disease. The most important of those is actually the amyloid PET scan. This is a PET scanner that actually detects amyloid within the brain. Unfortunately, Hawaii does not have a PET scanner yet, an amyloid PET scanner. We are in the process of getting one. I think Queens is going to be probably getting one sometime in 2026. I don't know when the date kind of shifts, but at least people are trying to get an amyloid PET scanner into Hawaii. Right now, if you're in Hawaii and you cannot travel away for an amyloid PET for a diagnostic, you actually need to do a lumbar puncture or spinal tap to get fluid to look at the protein levels in the fluid. So for dementia, at every visit, I train my fellows, you have to look at the ABCs. Activities of daily living. We know this disease affects your functioning. Behavior. The C, there are actually two C's. There's one for cognition, you have to do the cognitive test, but the second one, very important, is the caregiver. I always take the caregiver aside to ask them, aside from the patient, because in front of the patient, they will not tell me the truth. So I always separate and I ask the caregiver, how are you doing? Because we know caregiving is really difficult. We know caregiving can affect the health of the caregiver. And if you don't take care of your own health, sometimes you'll be the one who gets sick or even dies sooner than the loved one with dementia. So taking care of people with who are caregivers is a huge issue. And I think if your doctor's not doing that, or if you're a caregiver for a loved one, and the doctor's not taking you aside, if you have things to say, ask for a separate meeting so that you can talk to them personally. Disease progression is inevitable, and then education, constantly. This is a long-term commitment for the family. At the first diagnosis, I always ask for a family meeting and bring in as many people as you can because I really want everybody to understand. It's very unfair when people get angry with the person with dementia. They are not doing this on purpose. Their brain is not working. They're going into brain failure slowly, but it's happening. So it's very important that we educate everybody so that they understand this is not being done on purpose. So I'll talk very quickly about Alzheimer's disease. It was first described by Dr. Alzheimer in 1906. He called it a pre-senile dementia. His original patient was in her 50s, early 50s, I think. And she had a very severe dementia syndrome, which got rapidly worse. She died. In 1906, he got her brain at autopsy, and he described the plaques and tangles, which to this day are the hallmark of Alzheimer's disease. Again, it's the most common cause of dementia. The symptoms are short-term memory, orientation, and problem-solving problems. Behavior problems are very common in Alzheimer's disease. In some studies, 70 to 100% of patients will have some form of behavior problems. Some will be severe, some will be mild. It has a very insidious, slow onset and progression. The duration from diagnosis to death can be anywhere from 2 to 25 plus years. Some people progress quickly, some go very, very, very slowly. The average is about 8 to 10 years. This is Dr. Alzheimer in Germany, and this is his patient, August Dieter, who was that first lady, very unfortunate to get Alzheimer's disease at a very young age. This is what we find in Alzheimer's disease. We see certain neurochemicals. These are the messengers between brain cells. These chemicals send messages. We see acetylcholine, the memory chemical, is particularly low in Alzheimer's disease. So the messages are not getting back and forth between the brain cells. In addition to that, though, there's pathology happening. There are two abnormal proteins, beta amyloid plaques, which is on the bottom left, and then the neurofibrillary tau tangles, which is on the bottom right. Those proteins are strangling and killing brain cells. So we see neurons or brain cells dying in Alzheimer's disease. So if you look at that top right picture, that's an autopsy brain. On the left is a normal brain. On the right is an Alzheimer brain. You don't need a microscope to tell you that the brain on the right has lost mass. A lot of cells have already died. The risk factors, I've divided them into non-modifiable and modifiable. We still haven't found a cure for aging. Age is the strongest risk factor for Alzheimer's disease. And the second strongest is low education. These two, higher age, lower education, have been consistent in every study, in every country, in men and women, in every ethnic group. Higher age, lower education is linked to Alzheimer's disease. Traumatic brain injury is controversial. Some studies have found a link, others have not found a link. I would not recommend getting your head repeatedly pummeled. I just would not recommend it. Now people are laughing, and it is kind of funny, but that's the whole point in certain sports. In boxing, the whole point is to knock the other person out, to give them a concussion, basically. Now there's a lot of attention being drawn to it because of the National Football League, because they're noticing that these young, healthy men in their 20s and 30s with repeated concussions are testing on neuropsychological testing like they have Alzheimer's disease. So we know long-term this is not a good sign for them. Genetics, I have a whole slide on genetics. And then the modifiable ones are the cardiovascular risk factors, especially high blood pressure and diabetes, dietary factors, avoiding heavy alcohol intake. We know alcohol is toxic to the brain. Depression can be a factor, chronic inflammation, sleep apnea, hearing and vision impairment. There's more and more research being done on those two now. And now they're finding if hearing impairment is corrected, it slows the cognitive decline. So we need to be focusing on hearing and vision as well. Genetics, everybody is worried. When I have those family meetings, even if they don't ask, I tell them because I know they're thinking about it, right? My dad had Alzheimer's, am I gonna get it? Well, it depends. There are two major types of Alzheimer's when you look at genetics. On the right is the early onset Alzheimer's. These are people who get it in their 30s, 40s, and 50s. It's very, very rare. less than 5% of Alzheimer's disease is this early onset. You see it a lot in the news and in movies and things like that because it's so dramatic, so it makes for a good movie, but it's really not that common. That type of dementia, that type of Alzheimer's is very familiar. There have been 3 autosomal dominant genes identified. Autosomal dominant means if you have the gene, 100% you will get the disease. So for those families, I do recommend testing, and I do recommend that the whole family get tested and they get genetic counseling. There is a role of Down syndrome in this as well. For the late onset, family history is a slight risk factor, but part of that is longevity. We know if you live longer, if a whole family lives longer, there'll be more people in the age where they're at risk for Alzheimer's disease. So there is a slight increase in risk, but it's not a huge increase. It doesn't guarantee it. There's one gene that has been found to be linked to Alzheimer's disease. It's called the apolipoprotein E4 gene. If you have it, it increases the likelihood. But you can get Alzheimer's without it. You can have it and not get Alzheimer's. It's not a guarantee. So I don't recommend testing routinely unless you're considering taking some of the new drugs where testing is important. What about the protective factors? I'll show you some data again from the Kuakini study. This one looked at walking and developing new dementia 8 years down the road. And if you look at this graph, on the right side is the people who walk the most, more than 2 miles a day. On the left side is people who walk the least, less than a quarter mile a day. You can see the people who walk the least had almost double the risk compared to the people who walk the most. Similarly, when we looked at social engagement, on the right is high social engagement, on the left is low social engagement. You can see more than double the risk in those who have low social engagement. Blood pressure is very interesting. When we looked at blood pressure cross-sectionally, that means at the same time as we were measuring the memory tests, we found actually that high blood pressure seemed to protect. So you see that line, right? Anything below the line is protective, anything above the line is risk factor. So the blood pressure groups are low, normal, borderline, and high. It looks like high blood pressure has a lower risk. We were like, what? That doesn't sound right. So we were lucky. Our study had risk factor data from 25 years ago, from midlife. Most dementia studies don't have this. We did. When we looked at midlife blood pressure, we saw the opposite pattern. You can see among the high blood pressure, the relative risk was 2.5 times higher. And if we looked at the subgroup that was never treated, it was almost 5 times higher. So blood pressure is clearly linked to cognitive function. Now, when we first published this, people said, big deal. High blood pressure causes stroke. Stroke is linked with dementia. This is all related to stroke. But we had an autopsy study. Not only did our men volunteer for 60 years to come back over and over again, they gave the ultimate gift. They gave the gift of their brain at autopsy after they passed away. And we found in that high blood pressure group on the right, not only did they have more strokes, but they also had the lesions of Alzheimer's disease. So high blood pressure was not only linked to vascular stroke-related dementia, but also to Alzheimer's. This is really an important graph. On the left side, we have untreated high blood pressure. On the right side, we have treated high blood pressure. You can see in the untreated, high rates of Alzheimer's disease 25 years later. When you look on the right side, if you treat that high blood pressure, that risk goes back to normal. So treatment of high blood pressure is super, super important. So let me get now to treatment. There are 3 stages of Alzheimer's disease. You see the straight lines in between, right? The one on the left is the pre-symptomatic stage. Things are changing in our brain. Actually, you know those changes I talked about, the shrinkage of the brain, etc.? Guess what age they start? in the 30s. 30s was when all the decline in our body starts. It's not noticeable, but change in muscle, change in bone, change in lung function, all starts in the 30s. It's slow, but it goes gradually. So there's a very long pre-symptomatic phase where things are happening in our brain, we have no idea about it, okay? Then there's the middle bar, which is MCI, or mild cognitive impairment, and then after you've crossed that line to the right, that's the dementia. The green line, which is on the top, is cognitive performance. So you can see it's normal in the first phase, starts getting abnormal. In MCI, the testing is abnormal, and then it really gets bad after dementia. The blue line on the bottom is functional status. This is things we do every day. Can we bathe ourselves? Can we dress? Can we eat? Can we drive? Can we do all of those things? You can see it's normal, still normal even in MCI. They're still functioning okay, but it gets bad after people have dementia. This is the same version of this graph, very complicated. There's only one thing I want to show on it. There are two things if you look at the left side of this graph. CSF is cerebrospinal fluid. That's what you get by getting a lumbar puncture, a spinal tap. The proteins in the cerebrospinal fluid and the amyloid PET are abnormal many years before you get even MCI or dementia. That's why those are the tests that are being now used for the newer drugs. So for prevention, we really want prevention for the whole population, not just for people, but especially for people who are at high risk, and then early recognition, early diagnosis and early treatment of reversible causes. These are the FDA-approved treatments for dementia right now. So the first group is the cholinesterase inhibitors. You remember I told you about that chemical, acetylcholine. This one tries to raise the level of that chemical in the brain. There are 3 drugs currently, donepezil, rivastigmine, galantamine. There are no head-to-head studies. They're all about the same effect, so it really depends on which one your doctor is more comfortable with. There's another class of medication called NMDA receptor antagonist called memantine or Namenda. All of these drugs, at best, will provide temporary stabilization. They're not a cure at all. People will continue to decline, we know that. So patient education is really key, because if they're expecting a cure, they're going to be very disappointed. Some of these medications may cause a reduction in behavioral disturbances, so sometimes we use it for that rather than for the actual brain chemicals itself. All those drugs on the previous page, all they're doing is hitting the first bullet, which is trying to replace chemicals. So it's a Band-Aid at best. It's not taking care of the pathology, which is killing the brain cells. The brain cells are continuing to die, even though you're giving those medications. So there is some hope on the horizon. The new medications are beta amyloid antibodies. So if you remember the figure on the left bottom is a beta amyloid plaque. These are antibodies to that plaque, so they're trying to clear that abnormal protein from the brain. You need to have a diagnosis by either an amyloid PET scan or a lumbar puncture. It needs to be early in disease. If it's moderate or late stage disease, these drugs are not approved for that. Leqembi or lecanemab got full FDA approval in July 2023. They did show some clinical benefit. How much benefit and how long the benefit will continue is honestly not certain yet. The original trial was for 18 months. What will happen 5 years down the road, 10 years down the road? We don't know. These are newer drugs, so time will tell. It is expensive, and it's given by IV. So you do an IV infusion every 2 weeks. The cost of just the drug is $26,500 per year. That's just the drug. If you include the testing, the repeated MRI scans, the going to the infusion center, The estimate I got was 85 to 95,000 per year of all of it. So people have to really check with their insurance companies whether it's covered. Some insurances cover it, some don't. So you really have to check. It's not a cheap treatment. There is now a subcutaneous version. Subcutaneous means you give an injection under the skin. You know, like how people take insulin or something like that. So you can just inject it. You can be taught to basically inject it yourself, or a family member can inject it. But that's for maintenance therapy. The newer one is donanemab or Kisunla. They received full FDA approval in July 2024. This one is a little easier in the sense that the IV infusion is every 4 weeks rather than every 2 weeks. The cost is a little bit higher. Both of these medications have side effects. They're not 100% safe. The side effects that we see that we worry about are what we call ARIA, amyloid-related imaging abnormalities. In plain English, swelling of the brain or bleeding in the brain. Most of the time when we see these ARIA, they're mild, and often you just stop the medication, wait a little while, and restart it, and it can be okay. Sometimes they can be severe, sometimes they can be life-threatening. So it's a decision that patients need to make about are they willing to take the risk. We know that people who have that ApoE4 gene are at higher risk for ARIA. That's why for those patients, I recommend genetic testing, because I think it's really important, because the risk is different if you are ApoE4 negative or positive. So then they know the level of the risk that they're taking by taking this medication. Some hope on the horizon. Not a final answer, not a cure yet. Research really, really needs to continue. This is some of the graphs from, this was the original article on Leqembi or lecanemab in early Alzheimer's disease. You can see on this x-axis, it's time, 18 months basically, and this is basically looking at change. So going lower means worsening. The yellow line is the drug. The blue line is placebo, or basically not taking anything. And you can see the two are different at the end. The lecanemab gets worse slower than the placebo does. But they do get worse, okay? The difference is, so there was a 27% reduction in the decline. When we look at the amyloid PET scan, this is what we found. The placebo stays the same, or actually goes up a little bit on abnormal protein in the brain. Look at that lecanemab. That protein is being cleared from the brain. If the clinical data looked as good as this, I would be, wow, this is really, really awesome. It doesn't yet, so there's still obviously a lot more work that needs to be done. So some safety issues I'm going to end with. Medications. Overusage or underusage. People may forget to take their meds. I think even more dangerous can be they forgot they took it and they take it over and over and over again and end up in the ER with an overdose. Over-the-counter medications, especially with Alzheimer's disease, please be really careful not to give your loved one medications without asking the doctor. For example, have you all heard of Benadryl? Everybody's taken Benadryl for something or the other. It's an anticholinergic. In somebody with a normal brain, no problem. You get a little sleepy, no big deal. In somebody with Alzheimer's disease who already has low levels of acetylcholine, now you're depleting them even more by giving them Benadryl. They won't get sleepy, they might get crazy with it. So you can see extreme agitation or something like that. So you have to be very careful about what meds you give. Wandering. Having a medical alert bracelet is important. LJ and his team were crucial in introducing the silver alert bill in Hawaii. So now, just like Amber Alert for a child, if an older person with dementia goes missing, the search can start immediately. You don't have to wait for, those missing persons reports have to wait for a while. Now you can do it right away, which was great. Leaving the stove on can cause a fire, leaving the water running. Driving. Some people have been diagnosed when they first got into an accident. We don't want that. We want to find out long before. These patients are at risk for elder abuse and neglect, even for financial abuse. One of my colleagues wrote a really cool paper in Hawaii Medical Journal many years ago on excessive sweepstakes participation. It was a case series of a bunch of older people who lost a lot of money on sweepstakes. We found out many of them had undiagnosed dementia. We don't want that to happen again. Again, find it early so that everybody's watching out for these folks. So early diagnosis is key. Treat the cause, treat the complications, using an interdisciplinary team. Doctors can't do this on our own. We need all the help we can get from our friends, the nurses, the social workers, the therapists, the dietitians, everybody. Patients with dementia should have regular medical appointments, not just come back when you need something. They need to be monitored. Provide a safe and stable environment. Provide family education. Lots and lots of caregiver support. If you know somebody who's a caregiver, please give them support. Sometimes just staying with the loved one for half a day and letting them either take a nap or go out or something is wonderful, giving them a little respite. Legal planning, healthcare, financial planning, and then community resources. By the way, in geriatrics, AA is always Alzheimer's Association, not Alcoholics Anonymous, just to let you all know, okay. Or the Executive Office on Aging of the State Department of Health. Our goals of care are not necessarily keeping people alive forever. It's to improve quality of life, keep people independent and functioning. That's what they really want. Avoiding social isolation. I've had patients ask me that, or actually families ask me that. We have a picnic this weekend. Should we take mom? She's not going to remember anything. What I ask is, does she enjoy it? If she does, take her. Give her a good day. Give her as many good days as possible. So what if she doesn't remember tomorrow? Give her lots and lots of good days. And then care for the caregiver. So again, end up with a plug with the Alzheimer's Association Aloha chapter. Their website is awesome. You can look on the internet. They have caregiver classes, caregiver support groups. LJ and his team and I work together a lot. Just yesterday we were talking about going to neighbor islands to do some training there for caregivers. So we do a lot of things together. They can also provide you with information about physicians. So they do keep a running list of physicians who do dementia care. Again, medical trial matches, clinical trials. If you or your family are interested in learning more about clinical trials in Alzheimer's disease, they're the ones to help you with that. I will end here, and we still have about 15 minutes for questions. So thank you all so much for your attention. Before we end, though, I do want to say a big thank you to Donda, Gregg, the Japanese Women's Society, and everybody who has supported this. Thank you, Gregg, for supporting these community education sessions. And thank you also for supporting the Honolulu Heart Program over the last 60 years. That was really amazing. And also to the Alzheimer's Association for coming and sharing their resources today. So thank you so much, everyone.
I see that there's been studies regarding Japanese American men. Has there been any studies regarding gender?
Yeah, that is such a good question, and that's something every time I give a talk related to Honolulu Heart Program, people ask me, why not women? To be very honest, it was a mistake. 60 years ago, they thought women don't get heart disease, especially Japanese women don't get heart disease. Why bother to include them? Now we know, big mistake. Women certainly do get heart disease. It presents differently. It presents at different ages than it does in men. It should have been done, but the mistake happened in 1960 when they were planning the study, and I wasn't even born. And so, yeah, but a very good question. There have been other studies, of course, that have included men and women. One of the big comparison studies that we worked with, was actually only women's study. It was called the Nun Study, and it was white women, mostly in the Midwest. So we've done a lot of comparisons with them because they had a huge autopsy study as well. in some studies, actually, women tend to be at higher risk than men, especially for developing Alzheimer's disease. And it's more than just that women live longer than men. So yes, there are some differences for sure. Unfortunately, with our study, we only looked at men. All the offspring studies that we have done, we have included women as well. Yeah. So please go ahead. Yeah.
You mentioned the nuns
Nun study, yes.
And my memory of it is they were nuns that had problems with their brains, where it shrank and they had knots in them, but they functioned okay, and they didn't realize it after they did an autopsy on their brains, and they found that living in community contributed to their well-being.
So did everybody hear that question? No. Okay, I'll repeat the question. So she was asking about the Nun study. Actually, the Nun study was not only people who had dementia. The Nun study included all the nuns in that order who signed up. Some had dementia, some didn't. Some developed dementia over time as they followed them. All of them got autopsies. I guess it was very easy. For us, for getting autopsies, it took a lot of labor and time and effort and money. For them, it was actually quite easy because I guess when you become a nun, Mother Superior becomes your legal guardian. So they had to ask permission from one person, not from family members, which we had to do. They had a 100% autopsy rate. What they did find, as we found also, there are people who have those lesions, Alzheimer lesions in their brain, but don't have a dementia syndrome yet. They're in those earlier stages. And so they're still functioning fine. Again, why are they functioning fine and people with the same amount of plaques and tangles not? We do know if you have this much plaques and tangles, Alzheimer's lesions in your brain, if you have even one tiny stroke, you're much more likely to have dementia than if you have the same number of plaques and tangles and no stroke. So there are a whole lot of factors that were looked at. Again, we did a bunch of comparisons between the two groups. They were mostly white women. They tended to have higher education levels than our men. Our men grew up mostly on plantations. So they had a lower education level, not because they weren't smart, because they just didn't have the opportunity. Yes. I don't know where to look next, so.
Hi.
Yeah.
Can you hear me? Okay.
Yes.
Thank you for this presentation. Do you have genetic testing for dementia, or is it the same as Alzheimer's testing?
Yeah. The only one that we have genetic testing on is Alzheimer's disease that we know of. But obviously for the others, there's a lot of research being done. Because if there is a genetic component, of course we want to find out about it. Even the familial, the one I told you about the young onset familial Alzheimer's, 3 genes have been found. We know that there are other genes out there, we just haven't found them yet. So a lot of research going on in that as well. Okay. Yes?
My question on the research using the Hawaii Heart Association on men, is there a distinction between those are coming from Japan and those that were born in Okinawa coming to Hawaii?
Yeah, that's a very good question. So the question is about people born in Japan or born in Okinawa and compared to the ones who were born here in Hawaii. The vast majority of the men in the Honolulu Heart Program were Nisei, born in Hawaii. The percent who were Issei, born in either Japan or Okinawa, was much, much lower. It was like around 15%. So the vast majority were what we call Japanese American, born in the United States. One of the things we did early on in the study was do some comparisons with Japan and with a cohort in San Francisco. All 3 cohorts were 100% genetically Japanese, but different environments, and found that there were some big differences between just living in Japan, living in, again, genetically identical, right? All 3 groups were genetically 100% Japanese, but living in Japan, living in the US, living in Hawaii and living in the US, it was found that the lifestyle really changed. So definitely we know that diet, exercise, and actually smoking is worse in Japan. Everything else is worse in the US. We definitely found some differences. So heart disease, stroke, we know there are some differences between the two countries. There's definitely some influence of lifestyle. Yes.
My question is, how do you help those who say, and you did list on their vision, they're losing their vision or hearing impaired. So how do you help those people?
Yeah. It can be very difficult, but I would say make sure that you take them to the appropriate specialist to get it optimized. For hearing, the specialists now tell me the technology is so good with hearing aids now that the vast majority of people can be helped with hearing aids. Getting them to keep them on is not the easiest thing in the world, as all of you know. I have a lot of, in the past, I'd have patients who'd be talking about their hearing aids, and they'd be talking about, they're not working. I'm like, where are they? And they're in the drawer. Well, they are not going to work if they're in the drawer, So vision is a little more tricky because, some visual conditions, unfortunately, you try and treat them, but people still end up legally blind or completely blind, and there's nothing you can really do about it. You just do the best you can. But I would say at least get vision and hearing optimized by making sure they go to the hearing specialist, making sure they go to the ophthalmologist to get the treatment the best they can.
I have a presumptive diagnosis of frontotemporal dementia.
Okay.
And my neurologist just this past week said there was a blood test for, for dementia or Alzheimer's, and
Yes.
I actually had a blood drawn, but he didn't tell me what it's going to reveal. So I was just wondering, this blood test that I had to show if I have Alzheimer's or any form of dementia, is that, what will it show? What will the results show?
Yeah, so there is a new blood test for Alzheimer's disease. It basically measures those abnormal proteins I was talking about. It is FDA approved, so you can get the test. For the new medications, because that's one of the main reasons to get that test to me, for the new medications, the current standard is that you have to get those measured in a spinal tap. So the blood test isn't enough to use those medications, or get that amyloid PET scan. For currently, you need to go away from Hawaii to get an amyloid PET scan. So just the blood test may not. Now, if the blood test turns out positive, and if your neurologist feels like you may be a candidate, maybe they'll get you on to the other test to see if you qualify for the new medications. So that's what I can say about that, yeah. If the blood test technology gets better, who knows, in the future that might be enough for the meds. Yes, Donda has a question? Oh, sorry.
Hi. This is in regards to mild cognitive impairment. If you are at a bona fide doctor that understands it, and he goes through all the requests of lifestyle and the vascular, LUVI, and all these other tests, is there any drugs for mild cognitive?
Yeah, so the question is, are there any medications for mild cognitive impairment other than lifestyle? I would say lifestyle is good for everything. Those without dementia, those with dementia, lifestyle is important because it's just good for other parts of your body as well, right? It's going to be good for your heart, it's going to be good for your bones, it's going to be good for everything else. MCI, actually, if you have MCI and if you meet some of the criteria for being on the new medications, you can be on them. So just MCI won't get you on the meds, but if you have MCI and you have amyloid PET positive or the spinal tap positive, you might be able to get onto one of the new medications for Alzheimer's disease. So that's one thing to consider if that's a path you want to go down, yeah. I know there are people on this side, yes.
Yeah, if I remember correctly, a number of years ago, there was a study done here in Hawaii with Japanese American men looking at or trying to determine if there was an association between soy consumption and the incidence of all our dementia. And I was just wondering if there were any conclusions, definitive conclusions drawn, or if there was any kind of follow-up studies done on that?
Yeah, thank you for that question. That one hit the news in a huge way, and honestly, I wish it hadn't, because I mean, it was a well-done study, but it should have been discussed in the scientific community, not necessarily gone into the news that much. Whenever we look at any study, we want to look at replication. If a single study finds something, so we did find that high soy consumption was actually worse for the brain. You want to replicate it in different populations, in different sites, in different ways, to see if it's truly an association, if it's some kind of random thing. And unfortunately, it hit the news before it got to that stage. Other people have looked at this issue and have not found that. That's about all I can say. So, yeah.
Are brain games beneficial, and what type would be more beneficial?
Yeah. I'm not going to speak for any particular game. I do I believe in keeping brain. I do the things that I find fun. Because I know it doesn't really matter which type it is, just do things that you like. So I love numbers, so I do Sudoku, I do these weird math games that I know I'm weird, but I like doing that kind of stuff. I love reading. I grew up in India when the whole country of India had no television, so I grew up reading. And I literally cannot fall asleep until I read every single day. Even if it's one page, I have to read. So I read a lot. I do things that are fun for me. I would say find things that are fun for you and do those. There's really no proof that one type of mental activity is better than another type of mental activity.
You mentioned the Mediterranean
diet, yeah.
There's been a lot of studies regarding the Okinawan diet.
Yes. There have been a lot of studies, especially with longevity, about the Okinawan diet, because the Okinawans, are one of the blue zone areas, right? In our study, we've looked at something that we call the Healthy Diet Index. It's not specifically the Okinawan diet, and we do find that using healthy dietary patterns is good for every part of your body, not just the brain. But we haven't specifically looked at just that. Brent? Yes.
Hello.
Hello. That's Dr. Ueno, who should be up here talking with me, not asking me a question.
Those experts. So I have patients who watch TV, and they say, but I watch National Geographic, I watch History Channel. What do you say about that?
Well, I do think that's better than, watching something that's educational is certainly better than watching something that's not. But I still think that you're still just sitting on the couch, you're not socializing, you're not doing things. So I'm not saying stop watching TV, but add on in all those other things as well. Because I think they'll be good for, again, not just your brain. They'll be good for your heart, they'll be good for your bones and your muscles and all of your other things. So, yeah. Thank you, Brent. Okay.
What effect do artificial sweeteners have on this whole thing?
Artificial sweeteners, yeah. That's a very good question. I know there are more and more studies coming out showing that they're not good for you in many ways. I haven't seen anything specific about those and dementia. So I'm not sure. I don't know what the answer to that is. But I do think, though, they belong to the sort of ultra-processed food groups, which are now being shown to be bad for many parts of our health. So I would say try and avoid those as much as possible. I'm Indian, so I drink tea with milk and sugar. Without milk and sugar, to me, it's like sacrilege. But the amount of sugar I'm putting in now is so little bit, it's almost not sugar. I almost put it in just for the psychological benefit, I think. So I kind of did it gradually so that I could acclimate my taste buds to it. Usually I like it really sweet.
I have actually two questions. The first one is, could you opine on statin use and these conflicting studies about cognitive function, and you know, some are positive, some are
yes, yeah.
That's the first question.
Yeah, so statin use is controversial. We know that high cholesterol isn't really good for the brain. Statin use is actually controversial just in geriatrics in general. What is the ideal cholesterol? What is the ideal blood pressure for somebody who's 85, 90 years old? There's a lot of controversy, even in the field of geriatrics, especially for blood pressure, but even for lipids. I would say, in general, with our people in extreme old age, I would rather live with a little bit higher. I'm much more loose with blood pressure recommendations, with sugar recommendations. I don't go for very tight control because I have to then balance it with other things. Is it gonna cause them to fall? Is it gonna cause them to become hypoglycemic, which they may not recognize, especially if they have early dementia? So I'm much more moderate in very old age than I would be in somebody maybe who's 65 and has those conditions. The statin question isn't completely answered. You're right, there's a lot of controversy in the literature.
Thank you. And the second question was related to red light therapy. Like, it seems like there's some early studies about helping to improve circulation in the brain and cognitive function. Could you talk about that?
I haven't seen any really good clinical trials on that. So honestly, I don't know. I don't think there's enough information out there to give it credence one way or the other. Mm-hmm. Thank you all so much. You've been very patient. Thank you for your attention. Thank you very much.
Wow, I think we can all say we learned so much, Dr. Masaki. Just thank you for educating us. You know, so I have a proposal, an option to consider. We're looking for volunteers, and volunteers, I checked this off, hits 3 out of the 4, not diet. Physical activity, mental activity, and social activity. Who's a volunteer here at Kuakini? Raise your hand. All these people that raising their hands, see them. Whether it's volunteering at Kuakini or volunteering at, you heard the messages, right? But we're looking for volunteers. We're always looking for volunteers, so come join us. And you'll get all 3 out of the 4. Diet, I don't know. So thank you very much. Have a great day.